Everyone, we'll go ahead and get started. So first of all, I just want to welcome you all to Capital Clarity week 6 this week. I'd say week 6. It's been a long 6 weeks. So to stay in touch with all of the Idaho Freedom Foundation communications and future topics for Capital Clarity, please make sure to sign up for our email list at idahofreedom.org. You can sign up at the bottom of our webpage over there, or you can go to capitalclarity.com to watch previous episodes of Capital Clarity, or to see what we have coming in the future. Also, be sure to grab some of the literature we have on the table in the back. We were graciously given some copies of this report written by Dr. Singer about our topic today. And so if you don't have them already, make sure you at least grab a copy before you head out at the end of the day. And so I just want to kind of give a good overview of this topic before we bring Dr. Singer up to talk about it. Many of you are probably unaware that Idaho has received some really bad news recently. We just fell from 49th in the country to 50th in the country in physicians per capita. And many of you are probably experiencing this in your day-to-day lives. I've experienced this recently. I was trying to find a primary care physician for my wife and new baby. And the soonest anybody could see us was April. And then if I went to a different provider, they weren't going to be able to see us until September. And so you guys are probably experiencing something very similar. And so this physician shortage is very real. And we're in the Treasure Valley. Imagine living in a place like Kootenai County or Shoshone County, or even a more rural community like Rexburg, where it would be really difficult for you to be able to acquire primary care services. And this is just the new reality for not just Idaho, but many of the western states in the country. And this is partially due to an aging, growing population, but also coupled with a population of now retiring and burnt out physicians. The state's solution to this was to add, just this last year, we spent $12.7 million to expand our physician residency program. Currently, medical residencies are mostly subsidized by Medicare, but the state of Idaho also offers medical residencies, and we subsidize that to expand the number of slots for postgraduate medical training. But even though we will still double our medical residency spending by 2030, we'll still be short 1,700 physicians by that same year. And so relying on residencies alone can't fix the problem. What you see with medical residencies is that they're largely inflexible. They are concentrated in high population areas. If you look nationally, the East Coast has the lion's share of medical residencies, and the West Coast is largely ignored when it comes to placing doctors for postgraduate medical training. You also see that they're very responsive as well. So they're not responsive to the free market needs. So if we need more primary care physicians in Lemhi County, the medical residencies aren't going to follow those positions. If we're going to add medical residencies, more likely they'll be added where the population is. And then these small rural communities will just get ignored. And so what has Idaho done? Well, last year, we took a huge step in the right direction by passing the Bridge Physician Licensure Program. And what this does is every year, you'll see about 8,000 medical school graduates leave medical school and be unable to match with a medical residency program. And this isn't due to merit or really anything like that. It's because of a mathematical algorithm that pairs them with a residency of their choice. And then they go and receive that medical training. But we just don't have enough medical residencies in the country to accommodate all the medical school graduates that are leaving the schools. So we're wasting all this talent. A lot of these people end up going and doing other things like running restaurants or using whatever their bachelor's degree was there to support. And in the meantime, we're still struggling with the primary care shortage. And so the Bridge Physician Program was designed to kind of capture all of those graduates who couldn't land a medical residency, and gives them a year to practice under the supervision of a licensed medical professional, a physician, MD or DO, and to train them while they're waiting for a medical residency slot. And this is great because we get to leverage their talent. Keep in mind, these people graduated medical school, they're doctors. They just haven't been through the residency training. And so they're being supervised as they're learning and engaging with patients, and gaining experience before they go into an actual residency position. But here in Idaho, you only get 1 year and one try at that before you're cast aside, or you get a medical residency slot. So then the problem is that we have a compounding pool of medical graduates that have nowhere to go. And so and you see this in Missouri as well. So Missouri actually has the most robust bridge physician, or what they call over there, assistant physician program in the country. They are allowed to practice indefinitely. They're not limited to that 1 year. And they can apply multiple times to try and get into a residency position, but they still need to get into a residency to be able to become a fully licensed medical doctor. And so what you see though, is even though they have the most robust assistant physician program in the country, they're still projected to be short 3,000 physicians by 2030. And so this illustrates that even though we are capitalizing on this talent that has graduated medical school but has nowhere to go, we're still not fixing the physician shortage. They have nowhere to go after they have gone through their assistant physician program. And so we're proposing an alternative pathway. If you've been practicing as an assistant physician for 3 years under the supervision of a medical doctor, then you can apply for step 3 of the medical licensing examination. And then you can be a fully licensed general practitioner. Now, what people don't realize is in every state in the country, you don't need to complete a medical residency to be a licensed physician. You actually only need to complete, at least in most states, it's only 1 year of your medical residency program before you go and sit for the final step of the United States medical licensing examination, and then you become a fully licensed medical practitioner. And so we're capitalizing on this policy that we already have. And going back to what we had before, we had subsidized medical residency programs where we had apprenticeship programs where you learned from a doctor in that community. You worked with the patients in that community and eventually took over that practice for that doctor. And continued to serve that community. And that's what this program is designed to do. We're hoping to expand on the great progress that we made from the Bridge Physician Program last year, and help rectify the physician shortage that we have here in Idaho. Now, today we have Dr. Jeffrey Singer. He is a senior fellow at the Cato Institute. He's a board certified general surgeon serving Phoenix, Arizona. And he is president emeritus and founder of Valley Surgical Clinics in Phoenix. He has written extensively on many healthcare policy issues across the nation, and particularly the physician shortage here in America. And without further ado, please help me extend a warm welcome to Dr. Singer for flying out here and talking about this issue.
Thank you. Well, we don't have much more to add. Nicholas did a great job of summarizing the problem. I'll just throw a few more statistics out. According to the Association of American Medical Colleges, they project a shortage of primary care physicians by 2034, and that's not that far away, of anywhere from 17,800 to 48,000. According to a survey published in the Mayo Clinic Proceedings, 1 in 3 physicians and advanced practice nurses, that's nurse practitioners, intends to reduce work hours, and 1 in 5 physicians intends to quit practicing entirely, according to a recent survey. So we have an aging population, and we have a shrinking number of primary care physicians. And as Nicholas mentioned, Idaho, unfortunately, is ranked number 50 now, and it actually hit the ranking of number 50 in terms of physicians per capita before COVID. So after COVID hit, a lot of doctors, particularly in primary care, who had to close their practices during the lockdown periods, decided, you know what, maybe this is a good time for me to retire. So it's likely even worse than that. And all of us, myself included, have trouble getting appointments. Another thing about residency programs, when you get into a residency program, the majority of doctors who get into them don't want to go into primary care because, to be honest, primary care doesn't pay as well. So they tend to want to go into the specialties. So adding more money to open up more slots doesn't guarantee, one, that the people are going to choose to go into family medicine or primary care, and 2, that they'll choose to stick around the area in which they did their residency. So these are things to keep in mind. So a lot of people have a misconception about what it takes to get licensed to be a physician. And all 50 states are pretty much similar. My state of Arizona is just like the state of Idaho. So in order to be licensed to practice medicine, you have to have graduated a medical school, accredited medical school. Halfway through medical school, you take part 1 of the U.S. medical licensing exam, USMLE. Right before graduation, you take part 2. And then after you complete your first year of postgraduate training, they call it. In my day, they call it internship. After the end of that first year, you take part 3 of USMLE, and then you can get a license. Now, when I was doing my surgical residency at Maricopa County General Hospital in Phoenix, it's a 5-year program. After my first year, I took part 3. I got a license to be a general practitioner, and that allowed me to moonlight, which I did once or twice a week in urgent cares and emergency rooms to help make some extra income because I had a young family that I was trying to support. And then after I went through my 5 years of training in general surgery, then I applied for certification from the American Board of Surgery, and I took my certification exam and all that. Another thing people may not realize is that no states require any physician to become certified in any specialty. What I told you, that 1 year and USMLE is it. So, for example, if I graduated medical school and I decided I want to be a pathologist, and I do my first year of pathology residency. It's a 3-year program. So in that year, I didn't probably see a live patient, okay, because I was a pathology resident. So we're looking at tissue samples and slides and lab tests, maybe doing autopsies. I take part 3 of the USMLE, and now I got a license to practice, and I can go out and practice. So meanwhile, what are we going to do about this primary care shortage? Well, this isn't a cure-all, but this is something that helps. The first program that ever started was in Missouri, and it went into effect in 2017. And as Nicholas was explaining, when roughly 7% of all graduates of MD medical schools and 8% of all graduates of DO medical schools, osteopathic medical schools, end up not matching. The way the match works out, it was created in the 1950s as a partnership between it's called the National Residency Matching Program. And it was basically a partnership between the medical profession and the students. So prior to that, you start, like when you're looking for a job, you start interviewing in residency programs. This made it more standardized and simplified. So in your senior year of medical school, you start looking at residency programs that you're interested in, you interview, and they look at you, and then you rank your top 10, I think it was top 8 in my day, top 8 choices of residency programs in order, sort of like a ranked choice voting kind of thing. And then they rank their top choices in order, and then using a computer and an algorithm, what they try to do is match everybody's closest choice with each other. And you find out about this on the third Monday of March every year. It's called Match Day. And that's when everybody's nervous and you find out, did you get into your first choice or your second choice, your third choice? And like I say, about 7% of MDs and 8% of DOs find out they got squeezed out. There's nothing. Then you got a few more days that week where you could try to see if there's any available slots anywhere in the country that maybe they didn't fill and you can get in. And some do, but most don't. And now you got to wait another year to do this again. So now you're stuck in limbo. You got all this education and you got all these student loans and you can't work. So, what are you going to do? And you're going to maybe lose some of the skills and knowledge that you learned when the next year comes around to do this. So what they came up with in Missouri was they created this thing, they call it assistant physicians. Some places call it associate physicians. Here in Idaho and I think Louisiana, they call them bridge physicians, as a bridge between medical school and licensing. So in Missouri, they said anyone who has not completed the first year of postgraduate medical education, so they don't even make it contingent upon not matching. In fact, I got to meet a doctor and his wife there, Dr. Lyman Wastrell, who's in the Ozarks in Missouri, and he and his wife were in a residency program in San Diego, and they were miserable. They were not getting the education they were promised, and they thought they were being exploited. They actually ended up suing. When they heard about Missouri, they quit and moved to Missouri, and they've been practicing now for 7 years in rural Missouri in primary care, servicing patients in that community. And the way it works is you have to have a collaborative agreement with a licensed physician who oversees you. They don't necessarily, in Missouri, you don't have to be in that physician's clinic. You could be separate. In fact, Dr. Wastrell and his wife are separate, but they're really close in the same community. And this doctor has to be available 24/7. Any questions, any issues, and that doctor is also expected to monitor, to audit your practice and keep an eye on you, much like an attending would to a resident. Now, if you've been in hospitals and been seen by residents, the resident isn't coming in the room and the attending is holding the resident's hand. They're independent, but they have to report to the attending. In the surgical residency, we couldn't operate on anybody unless we got it approved by our attending. And usually the attending, unless we were already far along in our training, the attending wanted to be in the room with us when we're doing it. So it's the same kind of thing with the assistant physician. Now in Missouri, at the end of each year, you could just renew it indefinitely. I've argued, another thing people might be nervous about is it safe to allow a medical school graduate to be able to do this? Well, we allow, first of all, the average medical student, by the time they get their MD or DO, has had 6,000 hours of clinical training. This isn't the didactic part, like the anatomy, biochemistry, and all that. This is clinical training, 6,000 hours before they go into their residency. This is at graduation. Nurse practitioners who practice in 28 states, they practice independent. Independent. In the rest of the states, they have to have an agreement with a physician who's kind of supervising, much like with an assistant physician. They average about 1,500 hours of clinical training, and physician assistants, PAs, average 2,000 hours of clinical training. But only the physicians have to take the 3-step USMLE. Okay, so when you have so in terms of, is it safe for me to allow an assistant physician to work under the supervision of a licensed physician? Well, you seem to have no problems with a nurse practitioner or a physician assistant. So why not somebody who's got an actual doctorate in medicine? That's number one. Number two, if after just 1 year of practicing in a postgraduate program, including something that doesn't necessarily even involve direct patient care, like pathology, I could pass Part 3 of the USMLE and get a license to be a general practitioner, then it kind of begs the question, well, okay, so if somebody does, let's say, we can argue about how many years, but let's say you do 3 years under the supervision of a licensed primary care physician, and you also pass Part 3 of the USMLE, and during those 3 years, you're also, by the way, I should have mentioned, most states, Idaho and Arizona, are the same. They require doctors to take 20 hours of continuing medical education credits per year. So if these assistant physicians are being required to take, let's say even more than that, so it more closely approximates the education they'd be getting in a formal residency program, let's say 50 credit hours a year. So why shouldn't they be able to also practice independently after all of that and pass an exam as a general practitioner? Now understand, when you're a general practitioner, you're not a specialist. So to be certified as a specialist, the boards that do the certifying require you to complete an accredited specialty training program, a residency program, and then you have to sit for the boards. When I finished my 5 years of surgery, I had to apply to the American Board of Surgeons to take my boards, and there was a written exam and an oral exam, and the boards usually have you recertified periodically. So but a lot of people don't realize that. So no state requires doctors to become certified in any specialty to practice. So as an example, I'm a surgeon, and I've been doing this for 40 years. And I have to take my 20 hours a year of continuing education. So let's say, and this is realistic, how many lectures can I go to about how to do a hernia operation or a gallbladder operation after 40 years? It's kind of boring. I do because I have to, okay? So, but according to the board, 20 hours of accredited continuing education could be in anything. So I'm starting to get this real interest in psychiatry. So I'm starting to take continuing education courses offered in psychiatry because this is fascinating to me. And then after a few years of doing it, I say, you know what? I'm ready for a change. I think I'm going to be a psychiatrist. So I go change the sign on my door that says general surgery under my name, and I change it to psychiatry. I could totally do that in Idaho and Arizona, everywhere, because I have a license to practice medicine. And that license, the scope of practice of medicine is psychiatry, pediatrics, OBGYN, you name it, that pathology. So I could do whatever I want to do. I'm not violating any law, okay? So now that I do that, I say, I need some patience. Let me go to the hospital where I do all my surgery and apply for privileges in psychiatry. So if people, let's say, are admitted with a suicide attempt or something, and they need a psychiatrist to see them, I can consult. So they referred that to the hospital credentials committee. Every hospital has a committee made up of members of the medical staff who review applications for staff privileges. And I'll know all these guys because I've been going to this hospital for years. And they call me to the meeting and they say, so where did you do your psychiatry residency? I say, well, I didn't do a residency, but I've taken like hours and hours of continuing education courses in it. And, and I feel ready to do this. And they say, well, that's great, but we require you to have at least completed a residency and preferably become board certified if you want to come to our hospital. So come back when you've done that. So I walk out dejected, but I'm thinking, well, you could do a lot of psychiatry in the office. You don't need a hospital really for that. So then I say, I better notify Blue Cross and all these other health plans that have me listed in their panel as a surgeon. I want to be put over in the mental health provider panel so I can get patients. And so I contact them and they ask me the same, they have credentialing committees too, and they ask me the same questions. And they tell me, I'm sorry, but you didn't do any training in a formal program, so we're not going to list you in our list of mental health providers. So that means they're going to have trouble getting paid by insurance, but that doesn't really matter anyway. If anybody knows, if anybody's been to a psychiatrist lately, you probably know 50% don't take insurance because they don't like dealing with the restrictions the insurance companies put on them. I can't blame them. So most psychiatrists are cash pay anyway. All right, so I'll be cash pay. Then I say, I better notify my malpractice insurance company that I'm doing psychiatry. So I contact them and they ask me the same questions and they say, well, we're going to be happy to keep covering you for surgical malpractice, but if anything happens due to you practicing psychiatry, you're on your own. So that's where we stand. So did my license protect the public from a 40-year general surgeon starting to practice psychiatry on people? No, of course. In fact, the license protected me from people wanting to compete with me, like nurse practitioners or whatever. So, or other medical professions. For many years, the medical profession was successful in keeping out, for example, not allowing osteopaths, DOs. Now everybody's kumbaya, but in my early years of my practice, MDs and DOs were like enemies. So, but what protected the public? All of these private organizations that are looking out for their own best interests. They're concerned about their reputation. They're concerned about their liability risks. They want word to get around that they have poor quality doctors in their health plan or in their hospital. That's what protected the public. The malpractice insurance company who said, I'm not going to cover you unless you do a residency in psychiatry. So that's what protects people, not the licensing board. So getting back to what I was saying before with the assistant physicians, if an assistant physician gets licensed to be a general practitioner and decides, I want to start doing surgery at some hospital, no hospital is going to let that assistant physician do surgery at the hospital without doing a surgical residency. And by the way, becoming licensed as a general practitioner doesn't in any way prevent you from deciding one day you want to go into a specialty and apply for a residency program and do a residency. I mean, I was licensed as a general practitioner for 4 years before I completed my general surgery residency in Arizona. So there's nothing that stops you from one day deciding to do that. But another advantage of this idea of letting assistant physicians, well, first, a couple of things it does. Number one, it's putting talent to work because we have the shortage. So instead of having people wait around, we're putting in the work helping people who need to see doctors, primary care providers. Number two, by the time limit that we have now here in Idaho, that doesn't do really anything to address the primary care shortage because there's only 1 year limit. So it's good for that doctor. You bought him a year's time so he could try again next year. But after that, he's back in that pool trying to fit through that bottleneck called the residency programs that are producing doctors. So it really did nothing to alleviate the problem. And then kind of ironically, you're taking a license away from a doctor 1 year later after he's got a year of experience. So you would think the more experience you get, the more you kind of want that guy to be doing that stuff. So here he's 1 year out of medical school. He's had a year's worth of experience in primary care under supervision. And now you're going to say you can't do that anymore? So that doesn't make sense. And it's not helpful. In addition, as I mentioned earlier, most people who go into residency programs don't want to go into primary care. But if you arrive as a licensed primary care physician through this alternative track, by the way, this doesn't do anything to reduce existing residency slots or anything. It's just it's an adjunct to it. So if you come through this alternative track, so let's say you go to a rural part of Idaho and you've been caring for people in your community for 3 years, you take your exam, you've done all this continuing education, and you get a license to practice as a general practitioner, there's a much better chance that you're going to stay in primary care. Number one, you've been doing it for 3 years. Number two, you've been living in this community for 3 years. And one of the things that primary care clinicians love about being in primary care is they're part of, they have relationships with patients on a primary level in the community. So that doesn't guarantee that now that this doctor's got a license, the doctor's going to one day decide to seek an application to get into a residency program in neurosurgery or move out of state. That doesn't guarantee that, but it significantly increases the chances that that doctor is going to want to continue along that path, just now with a real license instead of this restricted kind of license. So I think that Idaho is a rural state. A lot of other rural states that are particularly hard hit by the primary care shortage should think about this kind of reform. Arizona passed an assistant physician bill as well in Arizona. In Arizona's case, it's renewable 2 more times, so you get 3 years. Kansas passed a bill, except in Kansas, it was really restricted. You could do it up to 3 years, but you have to have graduated from the University of Kansas School of Medicine. So if you live in Kansas, but you went to the University of Missouri School of Medicine, tough luck. I think that's kind of counterproductive for Kansans, but I'm not in Kansas. Arkansas also passed something similar. And then recently Tennessee passed a bill and Alabama passed a bill. But all of the states except for Missouri have cutoffs where after a certain amount of time, they say, we've given you enough of a chance to get into a residency program. Now it's tough luck. And I'm thinking it's tough luck for the patients, not because you just took away a primary care provider who you've given years of experience to and done nothing to address the bottleneck. So If there's any questions, I'll be happy to take them. Dr. Livingston, I presume.
Thank you for being here. Could you make a few comments or further your comments regarding third-party credentialing?
Third-party credentials.
In other words, you mentioned briefly the difference between the license and the credential, either given to you by an institution or going through the credentialing process with an insurance company or a malpractice company, something like that. But are you aware of any states in which credentialing is handled by a third party and would be good for all of those entities? In other words, you go through a credentialing process.
Well, there are some, but again, when it comes to licensing, there are some states that have like what they call an interstate compact, where to kind of smooth things, to make things a little more efficient in the license application process, the applicant sends all their information that they would be sending for a license. There's one central credentialing entity that process checks out, yeah, that it's true, he did go to that medical, yeah, he did pass part 3 of the US, they verify true, no felony convictions, all that kind of stuff, and then they share that with the compact state members. But in each of the cases, it doesn't change things because, again, this is just to get a license to practice. But that doesn't really assure quality. If it assured quality, we wouldn't have any malpractice suits, will we? And of course, everybody's aware of the number of, we hear reports about doctors who had their licenses suspended, for example, for sexual assault. And then they get their licenses reinstated and they're still practicing. We hear this all the time. So meanwhile, what is really assuring quality are when you're going to these private, whether they're nonprofit or for-profit organizations like hospitals or health insurance plans, and asking them if I could work here or work with you. And they're the ones who are much more concerned about your quality and the degree of your training and expertise, because they're the ones who are going to get hit with problems if you have problems. So they're the ones who are really protecting the public, and it's in their best interest to do so.
I guess the point is it's the credentialing process that protects the public, not the licensing.
But the protective credentialing process is performed not by the state licensing board. State licensing board just says, grad accredited medical school, passed part 3 of the USMLE, took 1 year of something after you got out of medical school, and you haven't had any felony convictions. But you know what? The hospital credentials committee was going to ask you the same thing, and they're going to check that out too. Yes, ma'am.
This is kind of a I don't know, behind that door question about, we have a high demand for physicians, and that's kind of driving the shortage. Improving health would lessen the demand for physicians. Does the Cato Institute have any sort of policies or any suggestions or anything to look for ways that we can reduce the demand for doctors overall? And ways, is there anything that the Cato Institute is promoting or trying to do to improve overall general health so we have less desire, less needs for doctors in general? And especially in light of what has happened over the last 3 years and certain requirements of people that they have to do certain things that may not necessarily be good for their health, which may then have the consequence of having to see a doctor because of things that the pharmacological companies were pushing. Or
No, I get what you're saying,
kind of
but we're a public policy research institute, so we don't do like medical research or anything like that. So we don't. That's out of our area of expertise and out of our lane. But related, what Cato Institute, and I've done a lot of work on, is also we advocate allowing the expansion of the scope of practice of a whole lot of other licensed healthcare professionals to the full extent of their training, which expands access to health service. So, for example, Idaho was very innovative in this, where recently they allowed pharmacists to prescribe and test for routine things. Like in Idaho, you can go to a pharmacist, and if you think you have a urinary tract infection, they can perform a test on you, and if need be, prescribe like say Bactrim or some routine antibiotic for it. Or if you think you have a strep throat, they could perform that swab test and put you on penicillin, and do a whole bunch of things that you don't have to take an afternoon off from work and sit for an hour in a doctor's waiting room when you know that's exactly what the doctor's going to do. So, and pharmacies are much more numerous than medical practices, and some are open 24/7. So Idaho was a revolutionary in that. Now a couple of other states, Montana and Colorado, have copied that. Other things that we've advocated, I have a paper coming out with one of my colleagues, Mark Jaffe, on that very soon. One of the other things that we've advocated, that I've written about, is since the 1990s in the U.S. military and the Public Health Service, Indian Health Service, and now in 6 states, PhD or PsyD level clinical psychologists, these are doctorate level clinical psychologists, who get a master's degree in clinical psychopharmacology and do 2 years of clinical rotations under the direction of a psychiatrist, are given permission to prescribe psych meds, so that people who are under the care of a psychotherapist, who if the psychotherapist decides, you're so depressed, we can't even make progress with talk therapy here, I got to get you on some medication. In most states, they have to refer you to a licensed prescribing physician. In fact, you can call me up. I'm a surgeon. I could write the antidepressant. Just tell me how to spell it and how much the dose is, because I never heard of it. But I could do it because I have a license. Okay. So in those states, and I've advocated for this, that they've allowed, Idaho passed that too, and they've allowed what we call RXPs, prescribing psychotherapists. So we advocate measures like that, expanding the scope of practice of what they call mid-level healthcare practitioners, nurse practitioners, physician assistants, et cetera. Now that has nothing to do with how to change your lifestyle to make you live more healthy, but these are ways of making it easier for people to get access to healthcare. Right? I'll get you next.
I'm a retired DVM, so I'm looking at the medical profession from the sister viewpoint. And first of all, I've got to say this is brilliant, letting people go through a pathway with a general practitioner in a local community, because that's really where the rubber hits the road. And so kudos for that. However, there are some elephants in the room here that we're not addressing, and my own district rep, Jason here, on some of this with the what's happened in the last 3 years and whatnot, which is that we're driving talent out at the other end. This is one of the elephants in the room, both with threats of pulling licensure if people don't get government boxes, if they prescribe alternatives, scientifically proven alternatives that are not politically approved. But also one of the big ones, which because I reached that age where I'm a consumer, I'm the age where I become more of a medical consumer. And I am appalled at the lack of training that MDs have in areas like nutrition for creating wellness, that we're just stock and trade in veterinary practice, where we had to keep our food animal supply healthy.
You're not going to have any arguments for me on any of this.
And I think we need to go back to, how are we even doing medical school? Some of our policies there, we're creating a culture of pill pushers rather than a culture.
You're not going to have any arguments for me on any of this. Yeah, but what we do at Cato is come up with kind of public policy proposals. We're not medical school.
But some of that, I think, kind of overlaps with public policy and how it through insurance companies, through other policies, et cetera, that all drives that. So anyway, but I would say that this approach, I would certainly encourage our legislators to take a look at what you're talking about here.
Yes, ma'am.
I want to go back further. Number one, we have a problem in medical schools. For years, the establishment medical community did try and restrict the number of medical schools. So we had a lot fewer practitioners coming up.
Mhm.
Is that changed?
Somewhat, yeah, but I agree with you. I mean,
Why doesn't Idaho, Montana, and I don't know, Wyoming have a medical school?
I think there's an osteopathic medical school that opened up here in the last couple of years. You know,
I mean, I heard about it, but I don't know how many, what they're producing.
along those lines, I don't disagree with you. I mean, if you look at the history of medicine, okay, the American Medical Association was created in the 1840s, and part of its mission statement was to get doctors licensed, which was to restrict competition, because there were about 5 different, what they called sects of medical practice in those days. So you're not going to have an argument for me on this either. And they like to keep the supply tight because it keeps this price high. But
Military option, do they have residencies? I know
there are some.
that there are, I believe that, I don't know what they call it now, but it used to be the Indian Health Service.
Yeah,
A lot of people got family practitioner residencies.
There are some, but again, there's no guarantee that they're going to go where you want when they get through it.
The problem with the military, even today, is they're having trouble getting residents. It used to be competitive, but since COVID, the military is having trouble getting residents to come in. And the reason is there's a 5-year commitment. And doctors don't want to be committed to 5 years after they do their residency.
Thank you.
That can be a
Yeah.
nice place.
But-
I trained as Portsmouth in the Bethesda Naval Hospital, and it was great.
But-
Great, but the point is, just saying that the military is a solution is fine, but there
I'm
has
not
to
saying it's a solution, I'm just saying they can offer it as a.
Yeah.
opening.
Well, and this proposal is an opening also. It's just another path.
Who run the hospitals here.
Pardon me?
The corporatists who run the hospitals here. I
Yeah.
mean, it came straight from.
And I would expect that the medical association is going to oppose it too.
Fired every single GP.
I would expect the medical association is going to oppose it too, because
Why?
I don't know why, except the only thing I could think of.
Hire back.
Well, no, because these doctors who come through the assistant physician pathway are not going to jeopardize the income of the existing doctors. These are doctors who, by nature of the assistant physician program, are practicing in underserved areas in primary care that a lot of doctors don't want to do. So it shouldn't be a threat. The only thing I could think of is this system that we have today. They work very hard for decades to get it the way it is. And this is almost like a workaround where they are not in control necessarily. So it's about wanting to maintain control, in my opinion. I'm speaking for myself here, but I'm a member of the medical profession. And I can tell you that since I've been doing this kind of work, I've made a lot of enemies out of my colleagues, but so be it. Yes, sir.
What's the insurance environment here in Idaho? I know I got a general back in California 10, 12 years ago who basically said, I can't afford the insurance, I can't afford to practice with the insurance.
I don't know the answer. I'm from Arizona, so I don't know. But malpractice insurance is, I can tell you in my state, in a lot of the country, that's not the main obstacle these days. It's all of the regulations and all the boxes that you have to check and that the government makes you do. And in order to comply with all of the regulations, it becomes so costly that most doctors go to hospitals and say, buy me out, let me work for you, because I can't even handle this. Plus you got lawyers who could make sure everything's being done right. I just want out of the responsibility. That's the big driver. Yes, sir.
I was curious as to what kind of advocacy there is for preventative medicine. Like, we have a Carl Health Center here, medical group that's more of a natural. You're not getting prescribed medicine per se, you're prescribed vitamins where you're going through light therapy. What kind of advocacy does Cato do, or do we have around here?
We don't get involved in medical science and making health recommendations or public policy researches. Do we talk about like laws and regulations? We don't talk about, whether one type of treatment is better than another. That's for medical schools and medical researchers.
How do you feel about preventative medicine?
Preventive medicine is a good thing, but there's a lot of unknowns about what really is preventive and what isn't. So I want to give somebody else a chance. So back there.
Okay, thank you. Say I go to see my oncologist, and she sends in a nurse practitioner. Should I be nervous about that?
I wouldn't. Most of these nurse practitioners working in oncologist's office, number one, the oncologist is probably taking responsibility because they're working in that office. And oncologist is also, down the hall if there's a question. And number two, nurse practitioners, particularly when they go into certain specialized fields, they develop a tremendous amount of expertise. There's a concept called right skilling. I don't know if you ever heard that term, right skilling, but it's basically training a person to do the particular task, not training him, not over qualifying him and not under qualifying. You want to get it just right. And unfortunately, our current system doesn't allow for much of that. For example, up until 1914, when the AMA commissioned Abraham Flexner to do what was called a Flexner Report. I mean, there's a whole lot of history here that's really, you'll get you angry. But first of all, the American Medical Association started accrediting medical schools, and then they fought for states to license doctors. They finally started succeeding around the late 1890s or so, early 20th century. And then the state chapters of the Medical Association made up the majority of members of the licensing board. And they would do things like say, if you, doctor, agree to a prepayment contract with, let's say, Kaiser, or a benevolent association like Knights of Columbus or something, where you pay a fee, like a retainer rather than fee for service, you're kicked out of the medical association. And you didn't want that because they're the licensing board. So a lot of our current arrangements were promoted by the organized medicine. Then they commissioned Abraham Flexner to do a report on what's the best way to do medical education. And he was a very well-known American educator. And Flexner said, first you need to get a bachelor's degree. And then after that, he recommended pretty much the way the medical schools are today, with a certain amount of, a lot of scientific research and all this other thing. As soon as that happened, just a whole bunch of the AMA adopted that, and the board, licensing board, said, we're not going to give a license to anybody who didn't graduate one of those kind of medical schools, accredited by the AMA, which adopted the Flexner findings. So a whole bunch of medical schools closed up. In fact, it was really tough on the African-American community. They went from 7 medical schools to 2. Now there's still 2, historically, Meharry in Nashville and Howard University in Washington, D.C., even though they had a better teacher-student ratio than the other medical schools because they didn't meet these Flexner requirements. And in those days, it was important for these African-American medical schools because during the Jim Crow era, you couldn't get into medical school otherwise. And and women started disappearing from medicine. Around the early 20th century, at least half the doctors were female. But because medical school and medical education became so expensive, a lot of families decided, well, I don't want to pay for my daughter to get a medical degree if she's going to get married and have kids, and all that money wasn't cost effective. And also just a lot of regular people couldn't afford to go to medical school anymore. So up until around the 1960s, most of the people who went to medical school were generally from pretty affluent families. That all started to change. They did a lot of reforms. Now, more than half the medical school graduates are female. It's all different now, but I'm just saying these are the things that happened because the medical profession was trying to basically get control over who could practice medicine. So it's important to keep that in mind when you think about what a license is all about and who wanted it. Be that as it may, that's the system we're under. So what I'm suggesting here is, okay, so if you're going to require a doctor to have a license, here's another way to license doctors. If they, instead of having to do 1 year in an accredited residency program before taking Part 3 of the USMLE, do, let's say, 3 years as sort of an apprentice under the tutelage of a licensed doctor, and then take Part 3 of the USMLE, and you can do it that way too. It's just another track. It's an adjunct to the existing system. It doesn't replace it, and it helps. Yes.
Yeah, my husband went to medical school here at Icon, so I'm really curious about this alternative route. So it's a DO program. So the states that have expanded this opportunity for physician's assistants to be able to practice for that 3-year period.
They're assistant physicians, not physicians. People, we always make the mistake.
Thank you. The states like, you mentioned Tennessee, Arizona has done this, and the other states. So after that three-year period is complete, and they don't get into another residency program, they don't match into a residency program, do they essentially get their licenses taken away after that?
Yep.
Oh, even in the state.
Yeah, which you would think, wait, so this person's got 3 years additional experience and now he can't do it anymore? 3 years since medical school and taking all these continuing education credits and everything else? Yeah, it doesn't make sense. I agree. That's why I don't think there should be time limits because, and not only that, but putting a time limit doesn't do anything to address the bottleneck. You still have the bottleneck. So you're buying time for people who couldn't match the first time, but you haven't, the target should be reducing the shortage of primary care clinicians, increasing access to primary care clinicians. You haven't done anything about that. You just bought a year or 2 or 3 for some medical school graduate who didn't get into a program. And by the way, they may find a program out of your state because they know I got 1 more year. I got to find someone. Okay, I'll take this one in Massachusetts or in Maine or something because otherwise I'm stuck. I'm out in the cold. Well, they left Idaho to go to Maine. So that's why, to me, it's counterproductive to put a time limit on it.
So then what is the solution then? You're saying that
I say the solution is to remove the limit. So like in Missouri has no limit. You could renew it. If these 2 doctors, Wastrow, they actually are very happy just the way it is. They have no, they said, I don't know, maybe someday if they create this extra pathway in Missouri, maybe they'll then get a license as a general practitioner. But as long as they can have this collaborative agreement, they have 2 different primary care doctors. This way, if one wants to go out of town on vacation, they got the other one. They're not without supervision. And they've been doing this for 7 years. And they got a very busy practice in rural Missouri. And they're very happy. And as far as they're concerned, they could continue along this indefinitely. But obviously, if they make it available to them in Missouri, where they could take Part 3 of the USMLE, they'll do it. But right now, they're just comfortable keeping going as it's going. They're providing primary care and getting more and more experience with each passing year.
so Missouri is the one that has removed.
Yeah, they never had one. Yeah.
That's the only state that has.
Yeah, and they were the first state to actually implement this. It was sort of created in Missouri. It's a Missouri concept, but several states have since done versions of it, like I said. There was a woman back there. You still have a question? Ma'am in the light blue shirt. You still have a question or you? Oh, okay. Sir? No, I was behind you. I'm sorry, I shouldn't point. Yes, sir.
So it sounds like there's a lot of us that are trying to get out from the corporate pressure of the St. Luke's and St. Al's. From a policy standpoint, is there an ideal destination that you would advocate for us concerned citizens to maybe work with or advocate to our representatives and senators that we should strive for?
I believe let 1,000 flowers bloom, okay? No type of healthcare delivery is good for everybody. There's no such thing as one size fits all. I think people should be able to access all types of healthcare from any type of healthcare practitioner. I don't think the state should stand in the way of you deciding you wanted to see a naturopath or try nutritional rather than pharmaceutical treatment. You're an autonomous adult. You should be able to make your own choices. And in a marketplace, a true marketplace where there's competing approaches to medical care and also competing models, whether it's, like I say, primary care or corporate clinic or whatever, let everybody pick what works for them and what they're comfortable with and what they think is the best value for them. And I don't think we should have meddling from usually people who are influenced by special interest groups to try to pick what people can do and have. Because you had a question in the picture. Pardon me?
Like most things, open medical choice.
Yeah.
How do you feel about that? A lot of surgery is going robotic, and a lot of telehealth is going into hospitals, I'm sure, on staff. How do you feel about that?
As far as robotic surgery is concerned, that's a great advance. Depends on the procedure. For some things, it's great. Prostate cancer, for example, some thoracic operations. Other things, it's not. It's fine if you want to do it that way, but you could also do it laparoscopic, or even open. I mean, it all depends on the procedure. But robotic surgery is here to stay and offers very good advances in certain situations. Now, as far as telehealth is concerned, telehealth is great, and it's a shame that we are so far behind largely because of licensing laws, okay? So during the COVID pandemic, first of all, up until the COVID pandemic, if you wanted to provide telehealth services to a patient out of state, you had to get a license in that state. So you get this situation where I live in Phoenix, and let's say I come up with some real exotic condition, and there's this doctor at UCLA in Los Angeles who knows more about this than anybody. So I make an appointment. I get on a plane. It's only an hour flight. I see that doctor. He puts me on some medication, says, I need to see you in 30 days to see how you're doing. And I have to get back on a plane and go see that guy for a 5-minute office visit because he can't provide telehealth services to me. We can't conduct this by telehealth unless he gets a license in my state. Now, during the COVID pandemic, because people were all kind of stuck indoors, most states suspended that, and they said healthcare practitioners can provide telehealth across state lines without a license. Then when the pandemic ended, almost all states went back to the old way. I'm very proud to say, as an Arizonan, in my state, that didn't happen. Governor Ducey said, well, let's just make that permanent. And the state legislature passed a law that said any healthcare practitioner in any of the fields, not just medicine, psychology, chiropractic, physical therapy, if you have a license in good standing in any of the 50 states, you could provide telehealth services to people in Arizona without having to get a license here. They require you to register with a licensing board so they could verify that you really are licensed and in good standing and wherever you say you are, because otherwise you could be a phony. But that's it. Arizona was the first state to do that. Since then, there are 5 other states, as I recall. Florida has a similar one, but it's not as comprehensive. There's certain health professions it doesn't allow to do that, but most of them they can. Also, Minnesota, Indiana, Kansas, and Delaware and West Virginia. You notice, by the way, by the pattern of states, it's not like some are blue states, some are red states. This, to me, is not a red state, blue state issue. This is increased access to healthcare. Everybody wants increased access to healthcare. So I think telehealth is a great thing. For those who are interested, you might have read this a few weeks ago in the Wall Street Journal. There was an op-ed submitted by Dr. Shannon McDonald, who's a radiation cancer specialist at Massachusetts General and a professor at Harvard Medical School. And she was talking about how she needs patients to follow up for cancer care. And because of these licensing requirements, she's been instructed by her hospital, because they don't want to get in trouble with the law, that when you start a telehealth appointment, because as you might imagine, Mass General gets a lot of people from all over the world. It's a big referral center. That you got to start off by saying, first, before we go any further, where are you right now? And if they tell you they're in a state where you don't happen to have a license, you have to say, I'm sorry, we got to cut this off. I can't talk to you. So she was talking about, she has a lot of patients in New Jersey, and she doesn't have a license in New Jersey. She has a license in New York, and in Massachusetts. So if she provides telehealth services to her New Jersey cancer patients, in New Jersey, it's a criminal offense. So what a lot of her patients do is, you may have read this in the Wall Street Journal, they go into what they call telehealth parking lots. It's sort of like cell phone parking lot at the airport. They cross the bridge into New York, and they wait in the parking lot and conduct their telehealth visit by phone. So now they're in a state where Dr. McDonald's licensed. That's ridiculous. So she wrote in this article, she's being represented by the Pacific Legal Foundation. She's suing the state of New Jersey because she's arguing that, along with a couple of doctors and a patient or two, they're arguing that violates what they call a dormant commerce clause. It's setting up an obstruction to interstate commerce, and also violating their First Amendment rights to talk to her patients. We'll see how she does. But if you're interested, I contacted her, and on the 27th of February, it's noon Eastern, so that would be 10 here. I'm having an online event. You go to the Cato Institute website, cato.org, and Dr. McDonald, her attorney, Cato's Director of Constitutional Studies, Anastasia Bowden, and I will be having a 1-hour discussion about this, and her lawyer's going to explain the legal rationale of the case, and Cato's scholar is going to comment on that. And so if you're interested in that, there's something you might want to check out. Go to cato.org, and that's on February 27th at 10 a.m. Mountain Time. Yes.
Just getting back to your assistant physician situation.
Uh-huh.
So they're going like year by year or 3 or however many years. Coming from a rural community, it's a unique context dealing with ranchers and farmers, loggers and miners.
Mhm.
And in my experience, a lot of times medical residencies don't particularly prepare doctors for that. So why not take this on one more step and say, if you've done 5 years with your overseeing general practitioner, that counts as residency.
Well, I won't argue against it,
Yeah.
but you brought up
That's the next step to what you're
but you
talking
brought up
about.
another point that I didn't think of, which is, so when you're doing an assistant physicianship in, let's say, a remote part of the state where there are loggers and ranchers and not the kind of people you encounter, let's say, in Boise or in, that's actually preparing you much better to serve that community than a residency program would. So that's a good point. Thank you. I think my time is up, right? All right, well, thank you very much, everybody, for attending.
Please give Dr. Singer one more round of applause. Thank you for answering all those really great questions and for a wonderful presentation. If you want to watch this presentation back, it'll be on capitalclarity.com or also posted on our social media through the Idaho Freedom Foundation at idahofreedom.org. Please be sure to join us again next week for Capital Clarity. We'll be having Greg Pruitt from the Idaho Second Amendment Alliance to talk about our gun rights here in the state of Idaho and what legislation could be coming through the Idaho State House. But thank you very much for spending the time with us this new day, and we hope to see you next week.